Welcome you today evening on behalf of Delhi Hematology Group and Dr. Dang's lab to this brief interactive session on minimal residual disease. Well, I have to say a few lines that when I came to Delhi about 30 years back, we decided from Chandigarh, we had come from PGI, we decided that we'll start our own lab. And that time we decided that the focus is only going to be one. The focus is going to be patients. So the lab philosophy is one. It has evolved around only one thing, that is focus on the patients. And you must be wondering why this slide out here. This slide, work is love made visible, has been what we've been practicing for the last so many, many years. Lab medicine, as you always know, has been a behind-the-scenes specialty. But I wanted to change it. Like all of us, we are all doctors. Basically, at heart, we are doctors. We decided to come into medicine because we wanted to come into medicine, not because we were forced to come into medicine. So I decided that why not do something different? So we decided the only thing we could do different was to make the behind specialty come to the forefront. And how could we do that? By giving totally personalized care, love and affection to all our patients. Believe me, in the last 30 years, we are in the clinic ourselves, either me or my wife Manju, 8 or before 8 o'clock. The samples are drawn by one of the doctors. The samples are processed under our supervision. Even a urine and a stool slide is seen by a doctor only. We don't have any technicians who are going to see that. So one thing very interesting evolved after that. During the course, I had the privilege of meeting so many patients, and patients of all kinds of ailments, and of course I come down to so many oncology patients. It may be soft tissue tumors, it may be hemato-oncology, but I came to meet, love, regard so many patients. And in return, I got something which cannot be compensated. I got love. I got love from all my patients. That little bacha clicking my finger when I'm taking a blood sample, those eyes looking up at me filled with tears and with hope, and I've always been there just to share with them. And I think that is what mattered. That's why I'm so happy that I've always been able to pinpoint unmet needs of the patients. And one of the unmet needs was MRD. So many patients of mine have suffered because they've not been able to have proper access to MRD. Here, Dr. Mahajan is here. I'm grateful to CanKid, Poonam Bagai. I do not see her. She should have been here by this time. Oh, hi Poonam, sorry, she's here. And above all to Mr. Sajid Shapu, who's Dr. Myra. We have the privilege of diagnosing and looking after. And so many names which I do not want to mention, but while I talk to you, their faces are just in front of me. And I've had the privilege that with you all, that we looked after them. I really hope that this concept of MRD catches on, more and more awareness created, and more patients are able to use these services. I can only say thank you. And thank you with gratitude. So pardon me for taking 1 minute more and playing this short clip, which actually says what I stand for. That is an attitude of gratitude.
फकीर बुल्ले शाह से जब किसी ने पूछा कि आप इतनी गरीबी में भी भगवान का शुक्रिया कैसे अदा करते हैं, तो बाबा बुल्ले शाह ने कहा, चढ़दे सूरज ढलदे वेखे, बुझदे दीवे बलदे तीखे, हीरे दा कोई मुल न जाने, खोटे सिक्के चलदे देखे, जिन्ना दा ना जगदे कोई, ओ भी पुत्तर पलदे वेखे, उसदी रहमत दे नाल बंदे पानी उत्ते चलदे वेखे, लोकी कहंदे दाल निगलदी, मैं तां पत्थर गलदे देखे, जिन्हां ने कदर न कीती रब दी, हथ खाली ओ मलदे देखे, कई पैरां तो नंगे फिरदे, सिर ते लब्बण छावां, ਮੈਨੂੰ ਦਾਤਾ ਸਭ ਕੁਝ ਦਿੱਤਾ ਕਿਉਂ ਨਾ ਸ਼ੁਕਰ ਮਨਾਵਾਂ ਕਈ ਪੈਰਾਂ ਤੋਂ ਨੰਗੇ ਫਿਰਦੇ ਸਿਰ ਤੇ ਲੱਭਣ ਛਾਵਾਂ ਮੈਨੂੰ दाता सब कुछ दिता क्यों ना शुक्र मनावा। तो ये था बाबा बुल्ले शाह जी का जवाब। आप भी कोशिश कर रहे हैं अपने जीवन में शुक्रगुजार होने की। अगर मेरे जीवन में कोई एक चीज ऐसी है जिससे सबसे ज्यादा बड़ी तब्दीली आई, वो था ये एटीट्यूड ऑफ ग्रेटिट्यूड। हर वक्त शुक्रगुजार होना शुरू करें, लिस्ट बनाएं किन चीजों के लिए आप शुक्रगुजार हैं। मेरा आपसे वादा है काफी लंबी लिस्ट बनेगी और आपके जीवन में तब्दीली आनी शुरू होगी।
I hope all of you agree to this. We are so lucky, we are so privileged that we became doctors and have the honor of looking after so many patients. Now I request Dr. Ajay Sharma to come over and give the opening remarks, please. Thank you, Dr. Ajay Sharma.
Thanks, Dr. Dang. Good evening, ladies and gentlemen. So it's nice to meet for our monthly meeting actually, because when Dr. Sonali sometime back suggested to me that they want to hold a meeting as a part of Delhi Hematology Group, I told her that we normally don't conduct these meetings in this format, but she suggested, so if we just change the format this time. And I also realized that let us change the style of our meeting so that it might bring a interesting flavor. So I think that experiment has succeeded. So thanks, Dr. Sonali, Dr. Dang. I think we are going to have a very different way of the meeting today, the normally monthly meeting that we have. So I am really grateful to Dr. Dang and this team over here and the lab staff that we are seeing. I think now we are going to have addition of one more lab in the diagnostics of the hematological malignancies and beyond that also. On behalf of Delhi Hematology Group, almost all of our members are present here today except one or two, in addition to the other members of the hematology group in Delhi. I really express my thanks to Dr. Dang and his team in Dr. Lang's laboratory, and I think we will try that we can continue this kind of experiment in the future meetings also. With that, I hand over the dais to Dr. Sonali to conduct the proceedings, please. Thank you.
Thank you, Ajay sir and Dr. Dang for making this meeting possible. I extend my warm welcome to all my teachers, esteemed seniors of hematology, to come here and grace the occasion. Let's start straight away with the scientific program. So I'll first like to invite the panelists of the first panel, that is acute lymphoblastic leukemia, minimal residual disease and acute lymphoblastic leukemia, Professor Saxena, Professor Sameer Bakshi, Professor Mishra, Dr. Mahajan, Dr. Burani, Dr. Ajay Sharma, Dr. Anil Handu, once again, thanks to all the faculty of this panel. These are the discussion points that we're going to discuss in the coming half an hour. And with respect to the first discussion point, that is impact of MRD on conventional stratification, we have some case scenarios. These case scenarios are from courtesy Dr. Mahajan. Thanks for contributing to the cases, ma'am. So the first case is for Dr. Mahajan only. This is over to Dr. Mahajan.
This is a 3-year-old female with standard risk ALL, and the karyotyping was normal. The FISH studies we all sent for MLL gene rearrangements, BCR-ABL, and TEL-AML at diagnosis. So these are really the conventional prognostic indicators that we all send. The WBCR diagnosis was just 4,000. So by all parameters, she falls in the standard risk criteria, whether we use the COG protocol or the BFM protocol. And we treated her as per our protocol with just 3 drug induction with dexamethasone, vincristine, and L-asparaginase. And the end of induction bone marrow showed her to be in morphological remission. Currently, we use just end of induction MRD evaluation. The COG protocol currently recommends a peripheral blood MRD evaluation on day 8 and an end of induction bone marrow MRD. But for a number of reasons, we just use a end of induction bone marrow MRD, and that showed a parameter of 0.1%. Do you want me to answer what we should
Any
do?
other comments from Dr. Bakshi, sir?
So, Sameer, what would you suggest we should do?
No, what is the question? Just
So, I mean, what I had intended to, the discussion point was that, before MRD was routinely used for evaluation, we would just have continued on standard risk ALL management. Mm-hmm. But now, with this available, it would have dramatically altered how we manage. So, what we had to, use this case to highlight that how dramatically MRD has changed, that we would have switched this patient now from the rather than continuing on the standard risk arm. And because she would have really received very little treatment based on the COG standard, she would have just received very little consolidation, she would have received only 1 delayed intensification, but just based on this parameter, by shifting her to high risk arm, she would have received intensified treatment. And this would have really, subsequent studies have shown that this would have altered her overall outcome, and how just this little parameter changes the treatment and changes the outcome of this child.
What are we practicing?
Absolutely.
So what do you do and what Dr. Sameer does?
Yeah, no, I think that's
so
what
I'll just,
all of
I'll-
us... Yeah.
So what we do, I think we will probably talk about it in the next few slides when we talk about the protocol, that is the nationwide protocol that we are following now.
Okay.
So I can just say what we did
Any
is
other
that
comments, sir?
we shifted
if
her
you're
to
not-
the high-risk arm, and we then re-evaluated MRD at the end of 12 weeks, which was actually 0.01%. So that is just I want to
So
just
we
share with you.
changed the scenario
Change
the scenario to a end consolidation MRD, which is looks like this, what is written at the bottom. So how will the management change, ma'am? Then you can take it up
So
further.
that week 12, it is 0.06 or is it 0.1? I couldn't understand the last.
Yes, sir. So
I think
one is
she
there's 3
intends-
situations, MRD negative, which is less than 0.01%. Other 3 situations are an MRD, which is
Okay, you're given different situations.
0.01 to 0.1 and more than or equal to 0.1. So either of these 3 situations, what will we do?
Can you tell me
Dr.
about
Mahajan,
your
sir.
protocol, which is the COG protocol you're
So in the
following?
COG protocol,
So if
if-
after 12 weeks, if he means
If
still
it is-
0.1, what do you do?
Yes.
then the child would become a candidate for bone marrow transplant,
So
and
are
then
you
you would
changing the practices
yes,
based on the MRD
yes,
at the
yes, we are.
So what we understand out of this is, ma'am, that week 5 and week 12 both are important.
Both
after-
are important. So if you are between 0.01 to 0.1 to 1% at this point, it really depends on what protocol you are using. So I think rather than we get into very elaborate, because you have a number of cases, and what it means is that MRD at the end of induction, based on what protocol you are using, would determine how you would treat the child subsequently, and would determine subsequent evaluation at a serial MRD
Dr.
monitoring
Sharma
and
has some
subsequent
comments to make,
treatment.
sir, please.
Dr. Mahajan, I just want to know, you are doing at the end of 4 weeks MRD 0.1%. So,
This child had 0.1%.
so right, so you change the therapy at this stage
intensified her
by giving,
high-risk arm.
and then you again did it 12 weeks.
This child was MRD negative.
Yeah, so you did go for the transplant thereafter.
MRD negative.
Yeah, I know. So, but the question is, Now, that is the standard line of management for the COG protocol, because we actually are not following this. So, because there are some
So that's what the
concerns.
agenda is, that we have three situations, case scenarios. So how our